time, Sunday afternoon, to come and listen. I am going to, I just want to put my camera on from the beginning. Then after that, I'm going to put it off. I don't know how we'll do this, Hassan, because it's not, so I wish I could find a way of making it more participatory, because that's probably the best way of learning, if I can call out a name. So, but I don't know who is here. I don't know who is here. So anyway, let's see how it goes. Okay, so guys, basically, I think Hassan had asked me, told me that the medical students wanted to maybe have some revision sessions. I don't know, when is your exam? Hassan, you're muted. When is the exam?
Probably in like 3 weeks, I guess.
Or 3 weeks, okay. No problem. So I think that this is probably very relevant to you, because I will just go through the exam thing. So it will be not the way I teach usually. It will be just through the exam thing, how the questions are usually asked in the exam. So without further ado, let me see if I can start. So I'll stop my video and I will share my screen. Okay. Hassan, maybe just keep your stay unmuted so that I can, if I need to talk with somebody, I can.
Okay, Doc.
Okay, so let's see, PowerPoint. Okay. Now, I was telling Hassan, one very useful thing that you could use in your revision is I have specifically an Instagram page that I use to ask questions. It's not updated very regularly, but it's quite updated. So let me just share this page. So, like for example, if we just go and have a look at this, these are some questions I did. These are some questions I did with regards to just the hand. Okay. So if you look at that, yeah, like this, ask what's the name of the deformity. Sometimes sometimes people answer, sometimes people don't answer. But this specifically, maybe the history could have been better. I just want to have a look at the responses that were there. A number of people said botonias, campylodactyly, Dupuytren's contracture, and clinodactyly. So if you look at this, you can clearly see that there is. Are you able to see my screen, Hassan? You are, yeah?
Yes, Doc.
Yeah, you can clearly see that there is a deformity involving the little finger, which is usually involved in campylodactyly. There is no history of trauma. Maybe I didn't say the history. There's no history of trauma, but you can see the proximal interphalangeal joint is flexed. Yeah, there's slight extension, maybe not as much, but because the patient is putting the hand on the table, there is probably slight extension of the distal interphalangeal joint. All right. So this is a clear example of a condition known as campylodactyly. Okay, so it may look like a botonias, but it's not. A botonias has got flexion of the proximal interphalangeal joint and extension of the distal interphalangeal joint. Okay, in this case, there's no history of trauma, there's no inflammatory condition. So this is a clear case of campylodactyly. All right. So, and what about this? In this case, you can clearly see that the patient has got ulnar deviation of the finger at the distal interphalangeal joint and at the proximal interphalangeal joint. You can see that, and that is the X-ray. All right, and this is a clear case of clinodactyly. That's a clear case of clinodactyly. All right, this is another case where you have a fracture that involves the elbow. The pediatric elbow is always a challenge to deal with. What is broken, what's not broken. In this case, what you have is a fracture that involves the medial side of the elbow. It's not a very common fracture. It's quite displaced. And sometimes you find it can actually be entrapped in the joint. You can actually find it is actually entrapped in the joint. And usually it may be associated with an elbow dislocation, okay, like in this case. So this is an unusual fracture. And sometimes even when you have reduced the elbow, it may be incarcerated in the joint, okay? So this is a bit unusual, maybe not undergraduate level, but to just show you how complex the pediatric elbow can be, yeah? What do you need to do to know as an undergraduate with regards to the pediatric elbow? Well, you need to know supracondylar fractures, okay? Supracondylar fractures are a must. You need to know fractures of the lateral mass. You need to know elbow dislocations, yeah? Sometimes you may need to know radial neck fractures. Sometimes you may need to know a nursing elbow and how you deal with that. So those are the things. So make sure that you will, the exam is a period of about 2 weeks, yeah? And for sure, you will get a question on the pediatric elbow, yeah, with regards to, most of the time it's a supracondylar fracture, but you may get a lateral mass fracture. Sometimes you may also get a complication that is associated with this fracture. So this is a fracture you can see over here. This involves the distal radius, yeah, and this teaching or this is to determine what are the parameters that are used. So you could be asked, how would you manage a fracture like this? Obviously, first thing that you need to be able to tell is that you're dealing with a distal radius fracture, okay? So when you're dealing with a distal radius fracture, there are a few things that you could be asked. So what are the parameters that are used so there are certain parameters that we look for. We look for the radial height, we look for the ulnar variance, and we also look for, on the lateral view, the volar tails. You can see all that is illustrated there. So obviously a fracture like this, if it is not reduced properly, you can see there's loss of radial height. You can also see that there is increase in ulnar variance. So in a case like this, the reason why you address this distal radius fractures is because if you do not do something about them, you will have a positive ulnar variance. A positive ulnar variance will invariably lead to pain at the lunate fossa. So that is the reason why, we address the distal radius fractures. Okay? So this is me, actually, this is my son illustrating heel walking. So I always tell the medical students, please, guys, make sure you know, make sure you know what are the myotomes, okay? So in heel walking, it's the L4 myotome that is being used. If you're walking with your tiptoeing, it's the S1 myotome that is being used. So make sure you know the myotomes. You really must know the myotomes. All right, of the upper limb, you must know the myotomes of the lower limb. Okay, that is more important than any crazy thing. Then sometimes I bring some unusual fractures. This, for example, is a fracture known as a tripod fracture. These are what is known as transitional fractures. Transitional fractures are fractures that you get usually when the patient is transiting from adolescent to the patient is transiting from childhood to, well, around the region of adolescence, okay? So around 14, 15 years. That's when you get this transitional fractures. And what happens in the transitional fractures? Because there's past growth plate. So you can see this fracture. If you look at the AP view, it is a Salter-Harris type 3. If you look at the lateral view, it is a Salter-Harris type 2. So this is what is known as a transitional fracture. Another transitional fracture is a tilo fracture, okay? So the anterolateral fragment of the tibia is loose, okay? So that is also known as a tilo fracture, okay? So those are some of the transitional fractures that you should know. So I think this is obviously an ulnar claw hand, all right? What's the diagnosis? Ulnar claw hand. So I think that this is quite a comprehensive, yeah. This is quite a comprehensive perspective of a number of orthopedic conditions. Some of the things may be quite difficult. Some of the things are a bit easy. Okay, this is another one, anterior inferior iliac spine, where you have attachment of the rectus femoris. And I think I've done quite a number. It's hard to say how many I have done, but I've been doing this for years and years and years. And really, if you go through all of this, I can tell you, if you go through all of these questions, you will find eventually you have pretty much covered most of the things in orthopedics, okay? And subscribing to it obviously increases the visibility. So I would say that, we can only go through so much in this short time, but that's one, okay? The other thing that I always tell medical students is there is a YouTube channel that I also run, okay, for Ortho tutorials. And in this, I have put various videos like examination of the elbow, examination of the hip, the shoulder, the foot, yeah. So I think that this is also good, especially in your clerkship, to have an idea about the various examinations that you're required to do. I mean, always, don't prepare just for the exam with a closed mind. You could be asked anything in the exam. But this is also tutorials, and I also have a podcast to go with it, which I've not been faithful in updating, but hopefully I'll be back soon. Okay. So, in brief, what am I saying? I'm saying that if you go through all the questions in ortho tutorials, I can't guarantee you get all the questions there in the exam, but there's a good chance that you'll get quite a bit of it in the exam. Okay, because there can only be so many questions that can be asked. All right, good. So without further ado, let me see if I can pull up this, okay? So so now I decided to basically go through a number of the various papers that we have done over the last few years. These are actually questions that I brought in the exam myself, or some of the questions that, but always know, don't dwell on these questions. Just know that these questions are supposed to guide you, yeah, as to what could be asked, but they are not at all 100% in what would be asked. So the exam basically has got two sections. There is a part which is data interpretation. There is a part which is data interpretation, and there is a part which is physical examination. Hassan, I don't know how we'll do this. I think it will be good Are you okay to ask one of your colleagues to answer? I mean, it's better if it's interactive.
I think they can just unmute and maybe answer, but in an orderly way.
Okay, that's fine. That's all right. Okay. So I will start with this question. Okay. I don't usually use this. Yeah, that's fine. So yeah. So now, can somebody try the first one? What's the diagnosis in this 14-year-old with a painful limb? 2 marks. So some questions are quite straightforward. Usually these questions are not for fluffing about. So don't have too many answers. Don't think too much. They are designed most of the time when they are being asked, they are designed to just be quick. Okay, no thinking. All right. So maybe Hassan, I can get you to go with the first one. What's the diagnosis in this 14-year-old with a painful limb without X-ray? Do you have an idea? And you know, the faster we go, the better. Hey.
Doc, okay, the greater truncata of the right hip. I don't know if that is normal, but
There's no history of trauma here.
Okay.
Mm-hmm. So now, if you have this, usually this, sometimes they may give you a clue and they will tell you that this patient, on examination, you find that when they flex the hip, that it goes into external rotation, okay? If you look at the X-ray, I'm presuming the right side is the left side, and the left side is the right side. So in this case, if you look at a line that goes from the superior margin of the neck of the femur, it does not quite bisect, the head, okay? It doesn't quite bisect the head. All right, I'm forgetting the name out of the top of my head. I think it's probably called the Trent Thorne sign. Yeah. So it doesn't bisect the head. So it's obviously not very what? Yeah. So this is called the Trent Thorne sign. Yeah. And the line is called the Klein line. All right. So these are very subtle, not very subtle, but subtle enough. Slip capitofemoral epiphysis.
Hi, Doc.
Can you hear me?
Yeah, we can hear you, but is there a way that you could use a cursor or something? Or you're using your iPad?
Oh, yeah. Sorry. Oh, yeah. Sorry. Thank you. Yeah. So, so if you look here, let me see. Yeah, so if you look here, this line here, all right, you can see that line. If you look at the line this side, that side as compared to that side, this side bisects the head of the femur. This side does not bisect. This line is called the Klein line, and this is the Trent Thorne sign. Okay, yeah. So, sorry, Trent Thorne's sign. All right, and in this case is a skiffle. If you have a skiffle, the history is quite a classic. Usually you find it's like a 13-year-old girl or 14-year-old boy. Usually they're a bit podgy, or maybe they're a bit fat. Okay, and you find that they are they have a specific limb. Sometimes it can be very painful. They can't bear weight. We call that acute. Sometimes we call that unstable. Sometimes they can bear weight. But that is one of the things that you do. Then the other thing that you also must do with this patient, any child who, whenever you suspect they may have slip capitofemoral epiphysis or something, you must always do a you must always do a frog lateral view, okay? So you must always do a frog lateral view, because sometimes slip capitofemoral epiphysis will show in the frog lateral view before it shows on the AP view. So you must always do a frog lateral view. Okay, so this is a sign that the child has got slip capital femoral epiphysis. What do we usually do? Usually, you'd obviously refer this to an orthopedic surgeon, and usually what the orthopedic surgeon will do is in situ pinning. So the orthopedic surgeon will take a pin and pin it over there. All right. So that is slip capital femoral epiphysis. What about the second one? That one is a bit more obvious.
I can try.
Go ahead.
I think the second one is developmental dysplasia of the hip.
Yeah, so the second one is developmental dysplasia of the hip. You can see if you draw the various lines, yeah. We have the Parkins line, you have the Hilgerina's line, okay? And we have the Parkins line, and it should be within the inner quadrant, isn't it? If you draw a line coming, if you draw a line that comes like that, and another line that goes like that, yeah, it should be within the inner quadrant, yeah? But in this case, it's not. All right, so it's not. So in this case, yeah, you have a slip. And also, if you can see the head of the femur, the ossification center of the femur, in this case, is significantly smaller than. Can you hear me?
We are not able to see your pointer.
Pardon?
We've lost the pointer.
Yeah, so this is the ossification center of the femur. Okay? This is the ossification center of the femur. And the ossification center of the femur is what? The ossification center of the femur is significantly smaller over here as compared to the other side. All right. Then we said about the lines. We said there is the Parkins line, okay? So the Parkins line just on the outer margin of the acetabulum, and then there is the Hilgerina's line, which joins the two triradiate cartilages, okay? And you find that in this case, yeah, there's developmental dysplasia of the hip. And then sometimes you can have what is known as the Shenton's line, which is a line you draw like that. And in this case, the Shenton's line is broken. You can clearly see that. So this is a patient with, and sometimes also when you come for the exam, you know, the aim of the examiner is to give you a clue as to what he wants you to know. So you'll find that he will try and he will try and guide you. All right. So in pediatric hip, make sure you're very well versed with slip capitofemoral epiphysis. You're very well versed with developmental dysplasia of the hip. You're very well versed with Patter's disease, yeah, which I don't have an image here, but just make sure you know how a Patter's disease looks like, and aseptic arthritis and transient synovitis. So pediatric hip always comes in the exam. Always comes in the exam. All right, we proceed. Okay, so can I get somebody to attempt this question? What is the diagnosis in number 2 and the diagnosis in number 2A and 2B?
I can attempt to go to A.
Okay.
It looks like a tibial plateau fracture.
It is a tibial plateau fracture. So you can see interesting tibial plateau fracture that's not quite described You can see the fracture line that extends all the way from the lateral side all the way to the medial side. This is not typical of the adult pattern. If you are to classify it as a growth plate injury, what kind of a growth plate injury would you have? What would you call this growth plate injury? So remember, at growth plate injuries, they use Salter-Harris type 1, type 2, type 3, type 4, type 5, okay? So Salter-Harris type 1, you just have the physis that is involved. Type 2, you have the physis. You have the metaphysis. Type 3, you have the epiphysis. Type 4, you've got both the physis, the epiphysis, and the metaphysis, and type 5, you have compression. I think all of us are aware of that, isn't it? All of us, we all know the Salter-Harris classification. Yes. So make sure you have a look at it, okay? Yeah. And I think really the purpose of this slide is usually have an open mind. When you come to the exam, just have an open mind as to what will be asked, okay? The examiner is not that tricky. Okay, there are 1 or 2 difficult questions, but most of them are straightforward. Okay. What is the next answer? Anyone wants to give it a go? The key is over here. You can clearly see here. So this is one which you may argue whether or not it's really above your level. And maybe I would say yes, and maybe I would say no, because all you need to do is to know the anatomy of the tibial spine and what attaches at the tibial spine. Anyone? The anterior cruciate ligament. So this is an avulsion fracture of the anterior cruciate ligament. Or if you say it, an avulsion of the tibial spine, no one will penalize you. All right. So I always tell people who come to my my ward that please make sure what you do is you read just small books. Don't spend time reading very large books, okay? Because all you're going to ask you is simple things like, what is their diagnosis in 3A? Can somebody tell us? Anyone knows? No, I'm not quite sure now when people are quiet. I'm not even sure if there are people in the meeting or they're not. Maybe I'll have a look. Oh, there's so many people in the meeting. So, anyone knows? Or how do you guys want me to do it? Do you want me to just rattle through all of these things?
I think discussion is better, Doc. The way we're doing it right. I think the way we are doing it now is quite better than you just going through everything.
You know, if we don't go through them together, then you'll find that what's happening is people get bored and people sleep. It's a Sunday afternoon. But we need to be quick. Maybe
I can go with that. I think it's a dislocation of the shoulder.
So the one in the B is definitely a dislocation of the shoulder. Yeah. And this is an important view of the shoulder. This is what is known as the axillary lateral view. They don't usually do it here, but it's an important view of the shoulder. And what about 2? No, so what about A? Anyone? Yeah, this is osteoarthritis of the shoulder. Osteoarthritis of the shoulder can be either 2 types. You can have one which you have primary osteoarthritis of the shoulder. In primary osteoarthritis of the shoulder, the glenohumeral joint is arthritic, okay? And there is no underlying factor. But you can have secondary arthritis of the shoulder in which the glenohumeral joint is arthritic because the stabilization of the shoulder joint with the rotator cuff has been removed. So we have what is known as calf tear arthropathy. Calf arthropathy is much more common than primary osteoarthritis of the shoulder. So this is, and somebody asks you why you say it's osteoarthritis of the shoulder. You can clearly see there's reduction of joint space. You can clearly see there is migration of the humeral head, and you can clearly see the subchondral sclerosis and subchondral cyst. All right. So one is that. So somebody would ask, you have to have an open mind. How would you go about managing this? Well, with regards to osteoarthritis of the shoulder, it depends on how bad it is. One of the things that you may need to do here is an MRI scan. The purpose of doing an MRI scan is to determine how good the rotator cuff is. If the rotator cuff is fine, then you'll do what is known as a primary, and the patient desires, you do what is known as a primary joint replacement of the shoulder, an anatomic joint replacement of the shoulder. If, on the other hand, the rotator cuff is not working, you may need to do what is known as reverse shoulder replacement, where in the socket you put a glenosphere, and in the humerus you put like a socket, a humeral component. Okay. So that is what it is. The other thing that you could be asked is, how would you go about managing sometimes shoulder dislocation in a 19-year-old? I don't expect someone to ask you that, but just in case, in a 19-year-old, if you dislocate your shoulder once, I think there is probably a 90 to 95% chance that you will dislocate it again. All right. So if somebody is very active and an athlete, I'll just go ahead and fix it. In a 40-year-old, if you dislocate your shoulder once, there is a 10% chance that you're going to re-dislocate it. Okay. So if you dislocate your shoulder, however, twice, then there is a 95% chance that it will dislocate again. So somebody is requiring dislocation of the shoulder, really, one should consider the patient for surgery. All right, so can somebody go number 4? Hey, I've got so many slides, and I have data interpretation, 1 hour, physical examination, 1 hour. So we need to get a move on quickly. Anyone? What's the diagnosis?
Could it be a
Pardon?
A buckle fracture?
Yes, this is but the proper name that we use for it is known as a thorax fracture. You can see this buckle over here. So it's very different because in a green stick fracture, you have a break in both the cortices. It may be incomplete, but you have a break in both the cortices. In a thorax fracture, you have a break in only one of the cortices. Okay? So this fracture, does anyone know how you can manage this fracture? Does anyone know how you manage a thorax fracture? A thorax fracture can just be managed with a wrist splint, just a wrist splint. You don't even need to put a cast. Obviously, in our case, I've not seen wrist splints for children, unfortunately. So sometimes I may even just put them on a back slap, but you don't need to put a cast on them because it's a stable fracture. It's unlikely to displace at all. So a wrist splint is how you go about managing it. Okay. In fact, when I was a registrar many years ago, over 15 years ago, when I was a registrar in Glasgow, the teaching there was to give them a wrist splint and don't even bring them back to the clinic. Okay. Now, what about B? Can somebody give us the diagnosis of B? So you can clearly see it's only one view that we have over here. It would have been good, but this view clearly shows, if you look there, you can see that the lunate is out, okay? And it is like a spilled sticker, okay? So this is a lunate dislocation, all right? This is a lunate dislocation. If you get it acutely, put traction, and usually you can reduce it back to place, and assess the stability. You may need to put wires. However, if you see it chronic, then it's something else. So that's a lunate dislocation. All right, what is the diagnosis of this 18-year-old with 2-year history of hip pain in 5A? Have you ever heard of a shepherd's crook deformity? A shepherd's crook deformity, okay? So a shepherd's crook, I will show you this. A shepherd's crook deformity. So if you have a shepherd's crook deformity, a shepherd's crook is what you would find it now, maybe sometimes in some churches, like I think the Catholic Church or something. It's something that the priest would use. But this is a shepherd's crook deformity, yeah? A shepherd's crook for shepherds, huh? Okay. Sheep, let me see if I put sheep. And you see, this is, you can see that, huh? That's a shepherd's crook, okay? So that is, you can see that's a shepherd's crook. So a shepherd's crook deformity is what we have over here. Yeah, a shepherd's crook deformity. And it could be found in many conditions. One of the conditions that we find it is in patients who have fibrous dysplasia. So this patient has a fibrous dysplasia. You can see that the femur has that deformity, the shepherd's crook deformity, okay? And this is what is known as a ground glass appearance. What about in B? Does anyone know what B is?
Are those multiple exostosis?
Yes, this is multiple exostosis. Sometimes it's known as diaphyseal aclasis, okay? But it's hereditary multiple exostosis, all right? And sometimes I think for you, number one is to identify. If it's a single exostosis, the management is depending on what symptoms it's giving you. You may excise it or just watch it. But multiple exostosis, the problem is, where do you start and where do you stop? And the other problem with multiple exostosis is you find that these patients, they may have other problems like angular deformities around the joints, or they may have things like limb length discrepancies. So that is the importance of knowing about it. So what's the diagnosis in 6A? Anyone? Diagnosis in 6A?
Fracture of the tibia and the fibula.
Yeah, but it has a specific fracture, because if you say fracture of the tibia and the fibula, it doesn't quite portray the way it's supposed to be portrayed. So it has a specific name. So what is the diagnosis? Pardon?
Pylon.
This is a pylon fracture, okay? So a pylon fracture is a fracture that involves the distal aspect of the tibia. You can clearly see. And it's different from an ankle fracture. Ankle fractures usually reside ankle fractures usually are from ankle fractures are usually from twisting injuries. Pilon fractures are not. All right, pilon fractures are from an axial force. Okay, so these are pilon fractures. Now, the most important thing to know about pilon fractures is that they have soft tissue issues. So usually we're not very fast to fix pilon fractures. Obviously, you're not making the decision. Somebody else will be. But pilon fractures, we're not in a hurry so much to fix them because of soft tissue issues. Yeah. Then what about B?
It's a distal femoral fracture with, I guess, popliteal artery involvement.
Yeah, so always be on the lookout. Patients with distal femur fractures, may have it. Specifically, patients with dislocations of the knee may also have it. So please always be on the lookout. Okay, always be on the lookout. All right. So sometimes you may be given something. Don't panic. Just have a look at it and think. So what's the diagnosis in A? What's the diagnosis? Spondylolisthesis, yes, you could maybe say that, but usually spondylolisthesis, we usually used to refer to patients who are spondylolisthesis. Usually, we used to refer to patients who are like in lumbar spine or something like that. In this case, there was trauma. So, what do you think it is? So it's a facet dislocation, okay, by facetal dislocation. All right. So the facets at the back have dislocated. And what level is it?
I think it's at the cervical spine.
Yeah, which level? So you count, okay? Let me put my thing on play mode. So you count, this is 2, 3, 4, 5, C6, 7, okay? So C6, 7. All right, what is the diagnosis of a patient with a painful back in B?
Ankylosing spondylitis.
Ankylosing spondylitis. You can clearly see the bamboo stick appearance. So look, that essentially is what is one station. That is one station in whatever. And I can tell you, yeah, it goes so fast, and you can get all the marks. Yeah, some people struggle, but some people just have an open mind. There are going to be tough questions that will be asked, but most of the questions you'll be able to answer. Any questions so far? I can see some things in the chat box. I don't know, Hassan, can you see any questions so far?
No, sir.
Pardon?
No, there's no question so far.
No. Okay. Yeah, that's fine. Just people are responding to previous.
I have a question.
Ask.
Could you just demonstrate the I think you called it a bamboo appearance in the ankylosing spondylitis?
Yeah, look, your guess is as good as mine, yeah, but I think this, all this, the calcification of the ligaments, it looks like a bamboo, does it? So the way the bamboo looks, you can see that straight, and that, and then this is, yeah. But you can also see it. You can also see it in even in AP views. Even in AP views, you can see the bamboo appearance. It's quite characteristic, but that one I think looks bamboo. Yeah, you can see in the AP clearly how it looks. It looks, yeah, you understand, it's clearer even in the AP. Looks like a bamboo. Okay. We proceed?
Yes, thank you.
No problem, that's fine. So, so usually it goes very fast, okay? Obviously, we've been going slowly because we've been covering. So what's the diagnosis here? Yeah, this is now typical. My questions tend to be a bit harder than most people. This was said by one of my colleagues. So what is the diagnosis? Somebody go very quickly.
Someone has written in the chat that that is an OA of the hip.
OA of the hip, okay. Two features. In this, you can see there is loss of joint space. There's a bit of subchondral sclerosis. There's maybe a little bit of osteophytes, okay? And the subchondral cysts are not yet there, okay? What's the treatment? So the treatment now will depend on the patient and the age, okay? If the patient is young, not to buy as much time as possible. If the patient is old, then what do? We consider doing a joint replacement, which is one of the most successful operations in that. Just know when you're asked, it's conservative and operative management. Okay, first you try conservative. If that fails, then operative management is fair. All right, so you remember we spoke about the pediatric elbow and the fractures that you must know. This is one of those fractures. What's the diagnosis here? Somebody know? What's the diagnosis here? Somebody know?
Someone has written in the group chat, terrible triad of the elbow.
So this is a child. This is a child. In children, we don't usually get terrible triad of the elbow. Yeah. So this is a child. In children, we don't get terrible triad of the elbow. So what do you think? If you look here, you can see there's a clear fracture line here. Yeah. And this is the capitellum, okay? This is the radial head. So this is what is known as a lateral mass fracture, okay? This is a lateral mass fracture. And I think that it is not a very common fracture, but it does happen in the elbow, okay? And it is a terrible, terrible fracture to miss. All right, not a great fracture to get. So how do you manage this fracture? So unlike supracondylar fractures, which will depend on the Gatland classification, yeah, these ones have another classification called the Milt classification, but I don't want you to bother yourself too much with it. Yeah, unlike the supracondylar fracture, which will depend on the Gatland classification, in this patient, what you want to do is you want to, in this patient, you want to manage them operatively. Yeah, especially if they're displaced, you really must manage them operatively because of the pool of the common extensor origin and also the unconused. So these ones need to be managed. Okay. What's the
just a quick question? Sorry.
Ask.
With pediatric fractures, I often have the problem of distinguishing like the growth plate with the actual fracture. Could you just maybe share how that could be improved?
It's difficult to. I agree with you. It depends on the area of the body. the wrist, you will not have a problem with this differentiating. The proximal humerus, the proximal humerus, you may get a bit confused. The femur, the tibia proximal, you may not. It is the elbow. The elbow is the one that is a bit tricky. Okay. Now, how do I say it practically? Well, one of the things you could also do is just Google, okay, and find out. Okay. And then there is a mnemonic called Crito. Okay. In the mnemonic Crito, we say that the capitulum, okay, the radial head, the internal epicondyle, the trochlea, and the olecranon and the external epicondyle. That will tell you, depending on the age, which areas of ossification have appeared. But if you're stuck, I mean, you just Google. It's a bit tough, though, I agree with you. Yeah, but this specifically is a lateral mass fracture. And it's a fracture that we don't want to miss. Okay? What is the diagnosis in this young man? You can obviously see that there's something that's affecting the metaphyseal region of the medial aspect of the proximal tibia and also the epiphysis.
Could this be Blount's disease?
This is Blount's disease, okay? This is Blount's disease, all right, which needs to be identified and treated appropriately. You can also see that it is quite severe, okay? And in this case, I think you'll need to refer for surgery to a pediatric orthopedic surgeon. Now, sometimes what we'll do is we know we're giving something which is hard. This is one of those questions that was sent by myself. And I know that I'm giving something which is a little bit hard, but the STEM will give it, okay? So this is a 16-year-old with nocturnal pain relieved by NSAIDs. Yeah? What is the diagnosis?
Okay, is that a tumor? I don't know. If it's a tumor, it kind of looks like osteoid osteoma.
Yeah, it is an osteoid osteoma, okay? And the stem gives it, okay? Yeah, but you can see it's sclerotic and there's a nidus in the middle. What are the two forms of treatment? I think in the past, there are people who may have done curettage, but now increasingly people are doing radiofrequency ablation. Then you may also get something, a little bit of a curveball, where somebody throws this at you. What's the diagnosis here?
Is this sclerosis secondary to metastasis?
It could be sclerosis secondary to metastasis. That makes sense. What else? This is also just osteopetrosis, okay? Osteopetrosis. Sometimes you get these patients, very difficult patients to deal with. You go in and there's absolutely no canal, okay? So this is known as osteopetrosis. Sometimes you may also get this, but you shouldn't be scared. You can see a 35-year-old elbow pain after a fall. Then you can clearly see something. The X-ray has been given there, and it does show something. Then you can see the MRI scan. And even if you look at the MRI scan, the final image clearly shows you what could be the problem. So what's the diagnosis? What do you guys think?
On the MRI, it looked like the triceps tendon was avulsed.
The triceps tendon is avulsed, okay? Yeah, you can clearly see, and I've tried to show it here. You understand? And the wavy line, you can clearly see the triceps tendon is wavy. Okay. All right. No problem. That's fine. 1 second, guys. I'm just getting a call from one of the doctors. Hello? Hi, what's up? Can you text? I'm just in the middle of a teaching. Yeah, I'm teaching undergrads. Okay. Oh, it's an admission. Just text me, then I'll just let you know in a short while. Yeah. Is that okay? Thanks, bye. Sorry about that. Now, what is the diagnosis in 7A? Sometimes you are really lost, okay? But you can see there's definitely calcification here, okay? So this is known as calcific tendinitis, okay? This is known as calcific tendinitis of the shoulder, and sometimes it can be quite painful. You may decide to inject a steroid, or sometimes you may just puncture it and do that, what is known as barbotage, okay? And you remove the calcification in the supraspinatus, okay? What about 7B? So if you're given an MRI scan, like that, what about 7B?
Is that a rotator cuff tear?
Yeah. So look, the consultant is not going to give you something ridiculous, okay? So it can only be a rotator cuff tear. If you're given an MRI of the knee, it has to be a very obvious meniscal tear or an ACL tear. All right? So just be, even if it's an MRI, don't get scared. Usually it is whatever. And you can clearly see here that there is a rotator cuff tear. What's the diagnosis in A and B? Okay? What's the diagnosis in A and B?
I think maybe for a stress fracture.
Is it? What do you think? It must be a crazy stress fracture. So you can see in A that the tarsal-metatarsal joint is completely gone. Yeah. The tarsal-metatarsal joint is completely gone. All right. So this is a Lisfranc injury. So a Lisfranc injury can be subtle, but sometimes it is it can be this obvious. You can see that this is completely gone. Look at that. That's the first tarsal-metatarsal joint. That's the second. All of it is gone. So the whole of the Lisfranc joint is completely gone. So this is a Lisfranc injury. Sometimes, though, if you're given an X-ray like this and you're told this patient is a diabetic, they came to the clinic, they didn't have any pain, this is the way sometimes a Charcot foot can also present. Okay, a mid-foot Charcot can't present like this. So yeah, mid-foot Charcot can also present like this. All right, good. What about B?
Subtrochanteric fracture.
The subtrochanteric fracture, okay? So subtrochanteric fractures, these fractures don't do very well unless they're operated. I always tell the students who I teach that intertrochanteric fractures are not bad. They can sometimes escape with traction, but subtrochanteric fractures are really bad. They need operative fixation. So what's the diagnosis in A and in B? A, you can clearly see that there are a number of lesions here. There's a lesion here. There's a lesion there. There's a lesion there. There's a lesion there. And B is there is a lesion here. Okay, so what is A and what is B?
For B, I'd say maybe a burst fracture of the vertebra.
No history of trauma.
Oh.
Could A be metastasis and B be POTS disease of the spine? A be metastasis and B being POTS disease or TB of the spine.
Yes, so you can see over here in A that the whole of the body is involved. The whole of the body is involved. Part of the body is involved, but the discs are spared. But here, the body and the discs are spared. And you can see also there is some edema around the vertebrae, unlike in this place. So this is TB of the spine.
Okay, quick question.
Mm-hmm.
The lesions on A, how do you differentiate that from fat pads when you're looking at MRI?
From what?
Fat pads, sorry.
Well, you would not expect fat pads in the MRI unless, you know, fat pad, what would they represent? You know, I don't think you'd expect any fat pad when you look at the MRI like that. Okay. And obviously also the history of the patient. You know, the patient is in pain and you can clearly see that there's a number of lesions that are spread like that. The thing that you're thinking about is either metastasis or even something like a multiple myeloma.
Okay, thank you.
Okay. All right. So what about this? What's the diagnosis in, this is an easy one. What's the diagnosis in, see what's required of an undergraduate is very little. What's the diagnosis in 10A? The diagnosis in 10A is what? Is you can clearly see here. You know, you don't have to think too much. This is a calcaneus fracture, okay? A calcaneus fracture. And you can clearly see the CT scan shows a calcaneus fracture. And what is the diagnosis in B? This is a very common question in the exam.
Supracondylar fracture of the femur.
Yeah, supracondylar fracture of the humerus. And you know the way it goes, supracondylar fracture of the humerus, it may easily go sometimes, not commonly, but don't forget that you have to do a neurovascular exam because it can go with injury of the whatever. So look, guys, we've done an hour already. Yeah, I suggest we take a 5-minute break or something like that. And then we proceed. Now, we could either proceed to the physical exam. What I will do, because I realized we've done quite a number of questions. I think we've probably done so far about 15 or so questions. Yeah. What we can do with regards to the physical exam, we can move to the physical exam. And then what I will do is I will post some of these questions I've already posted in I've already posted in, what is it called? In Ortho tutorials, but I will just repost the whole thing in Ortho tutorials. Is that okay? So let's take a 5-minute break so that, okay, is that okay? Do you have any questions before we take a break?
There's nothing on the chat box.
There's nothing on the chat. Okay, no problem. Let's take a 5-minute break and then we will whatever. Okay.
Okay.
Yeah, so we should be back by around 3, it's 3:08. Can we say 3:15 we are back?
Yes, that's fine.
That's fine. Okay. I will I'll just mute myself.
I think we can start, Doc.
Okay, you can hear me?
Yes.
You can hear me? Very good. Okay, so let's go to physical exam, okay? I'll try and see if I can do this quickly. All right, and we'll do an hour of this and we'll be done, okay? So, I think as a rule, just try and go through all the physical exams of the various aspects of joints. Those are the things that you'll be asked, okay, in the exam. Now, I have a series of videos here, and I'll go through some of them. So this is a video. It's probably not a great video, okay? But trying to demonstrate a sign. All right. It's debatable what you'd say this sign is. Somebody may say that this could be a reverse Fallen sign. All right. But also the person is trying to check how strong the extensors are. Okay. So not a great one, I would say. Okay. But this is, can somebody tell me what the diagnosis of that is? Can somebody tell me what the diagnosis is? So with regards to the hand, this is paronychia, okay, which is an infection of the nail fold. And for you guys, I want you to know a number of things with regards to the hand. I want you to know paronychia, which is the nail fold, caused by organisms like staph, okay? Initially, you may treat antibiotics, but later you will need incision and drainage. All right, that is paronychia, okay? The next that you need to know is that you could also have a flexor tenosynovitis. I don't think that it is there in any of my slides, but this is something sometimes we bring in the exam: flexor tenosynovitis, which is an infection of the flexor tendon sheath. It is characterized by 4 signs. We call them the carnival signs. So there is a fusiform swelling. There is pain on passive extension. There is pain and tenderness, okay, of the flexor tendon sheath. All right, and it is held in a flex position. I think I need to show you this. Flexor tenosynovitis, okay. Flexor tenosynovitis, okay. So this is how it looks like. Okay, you can see this here. Yeah, very important. So you can see that the finger is held, it has a fusiform swelling, it's held in a flexion position. If you passively flex it, there is pain, and if you touch it, there's also pain. Okay, these are known as Abraham carnival signs. Okay, so this is flexor tenosynovitis. Very, very important. Very, very important to know. All right. If you get it early, you can treat it. You can give antibiotics. Otherwise, you need to do incision and drainage. Then you can also have herpetic Whitlow. Then you can have an infection of the flexor tendon palm space, which is known as a phelon. Okay. So those are some of the hand infection. Somebody who has so much background noise, I don't know who that is. All right, so please make sure you know all aspects of the hand infection. Okay, this is a common question that's usually asked. Okay. This is called the Finkelstein's test. Okay. And it is a sign of decurving stenosynovitis. Okay. So what's this decurving stenosynovitis? Decurving stenosynovitis is stenosynovitis involving the first extensor compartment of the wrist. Okay. So there are two muscles that are found in this compartment. All right. So there are two tendons that are found in this compartment. Number one is the abductor pollicis longus, and number two is extensor pollicis brevis. So sometimes they can be constricted here at the level of the wrist, all right, in the tendon sheath, and they become very, very painful, all right? This is what is known as a flexor tenosynovitis. Okay, this is what is known as decurving stenosynovitis. What is the treatment? Well, the treatment is splinting, and sometimes they give them a steroid injection. It's usually quite common, especially in mothers who are nursing their kids. It's not a great one, but what it's trying to show, even an ultrasound, it's trying to show that there's injury of the extensor tendon. So this is a mallet finger. A mallet finger is an important thing to know, really. When you get a mallet finger, the treatment is what is known as a mallet splint, okay? A mallet finger is treated with a mallet splint. So please make sure you know how to treat it, because it's also known as a baseball finger or something. If you don't treat it well, I mean, this really can lead to a swan neck deformity, okay? So as you may see in one of the pictures that we will have a look at later, all right? So mallet finger. So mallet finger, make sure you know you treat, don't miss it, okay? Sometimes patients may come late. They have had an x-ray, nothing has been done. Sometimes an x-ray may show a fracture, but make sure you don't miss a mallet finger. Okay. Treatment
I have a
option.
question.
Ask.
How do you tell the difference between a mallet finger and a swan neck deformity?
Good. A mallet finger, usually it's just the extensor tendon that is gone. Yeah. So what happens is you just have the finger you cannot extend the distal interphalangeal joint. But a mallet finger can complicate into a swan neck deformity. In a swan neck deformity, what you have is a hyperextension of the PIP joint and flexion of or loss of extension at the DIP joint. That's the difference between the two.
Okay, thank you.
So if you have a chronic mallet finger, it can lead to swan neck deformity. Okay, so this is the knee, all right? This is just a patella tap. It is just to see whether there's an infusion. And make sure you know all the tests with regards to the knee, okay? You really need to know all the tests with regards to the knee, because, you know, you could be shown a video and you ask, what test is this and what does it signify? So these are patella tests, just checking for effusion, all right? You guys know what this deformity is?
Gunstock deformity.
Gunstock deformity, all right? Caused usually by a supracondylar fracture of the elbow in children, yeah? Can also happen in adults, yeah? And it can lead, especially chronic, to tardy ulnar nerve palsy, okay? And you guys know this sign. What is this sign? Though not very well illustrated here. Not very well illustrated here. But what is the sign?
Froment sign.
Froment sign.
Froment sign. Can somebody explain to me about the Froment sign? What is a Froment sign? What does it illustrate? Why does it, of course, it illustrates ulnar nerve injury. Why does it illustrate it? What happens in a Froment sign?
Okay, so because you have ulnar nerve injury,
you have overcompensation done by the median nerve, which innervates the flexor pollicis longus. So that's what causes the excessive contraction of the thumb when you're trying to pull out the paper from the patient's thumbs and index finger.
Yeah, so what happens is the patient is trying to, what the patient trying to do? The patient is trying, you tell the patient to hold the paper between their thumb and the index finger, okay? And what happens is that they find that they're struggling to do that. They're struggling to do that because the adapter pollicis, which is applied by the ulnar nerve, is injured. So what happens? They, without knowing it, recruit the flexor pollicis. Okay, so that is the ulnar nerve. Okay, this one. The person was setting it, just put this, which is about 1,500 to 2,000. Okay, we know the name of the test here.
The Allen test.
This is the Allen test, and it's to determine about the vascularity of the fingers. Okay, and this one is for checking brachial plexus injury, also known as the trumpet sign. All right, so that is one set gone, okay? So this one is, what is the test here? Can somebody tell me what this test is? What it does test for? Somebody see it?
Anterior drawers test of the ankle.
This is anterior drawers test of the ankle. Okay, usually you find it in chronic ankle injuries. What management of a patient with chronic? First, what is a chronic ankle injury? Ankle sprain. A chronic ankle sprain is an ankle sprain that has happened for what? An ankle sprain that has happened more than 6 weeks ago and has not settled. Okay. So you do that, and the management of this ankle sprain is rehabilitation. So you need to send them for peroneal strengthening. You need to send them for pre-varization, also proprioception, and range of motion. Okay. If that fails, then you may need surgery. Okay, in terms of what is known as a Brostrom gold. Okay. This is a child that I operated a few years ago. Yeah, and somebody tell me what the issue is here.
Is that the high steppage gait?
This is a high steppage gait, okay? This is a high steppage gait. And you can have a number of gaits, okay? Please make sure you've gone through all those gaits. I think I will illustrate them here. I think there's one video I did here, which should not take us too long. Let me see. Gait abnormalities. Well, it's 3 minutes, but so gait abnormalities. Please, you can watch this video. I try to show the various kinds of gait abnormalities.
So the next thing that I will do is I'll ask George to walk.
Normal gait
compared to,
but you can see that is an antalgic gait where you have a
then
short
the next
stance
gait
face.
that I will
illustrate
is
and then
gait.
you can have a patient who has
the pelvis. Let's say on this side,
and I'm trying to explain
your body will use
Trendelenburg gate. You see the Trendelenburg gate the way
on this side because my trunk is stopping my pelvis
to stop the pelvis from
falling.
Drooping there.
There's gaits that are there. A high steppage gait may not necessarily be due to a high steppage gait because the patient cannot clear the ground. What they do is they walk like that in order to enable them to clear the ground.
And we can treat this sometimes. We do a tendon transfer. Yeah.
And you can have a circumduction gait. And a circumduction gait is a gait that you get in patients with a stroke or hemiplegia. The patient walks like this. It's usually in patients with stroke.
Okay. So, and
gaits, obviously. Okay. So you may find
you can get a scissoring gait in patients with cerebral palsy. So there's a very high and a short leg gait. Okay.
And you may get patients with a short limb gait.
Okay.
But we cannot go through all.
So please make sure you have a look at all the gates. Okay, please make sure you have a look at all the gates, because you will definitely be asked. Okay. Yeah, common peroneal nerve palsy. This is I'm sure all of you probably have seen this video. What's the diagnosis here? Somebody see it? What's the name of the test?
Is it the Gowers test?
This is a Gowers sign. Yeah, Gowers sign. Okay. Very sad test sometimes to find. Please, guys, like I always told you, the ones I've taught, and I always emphasize even in my lectures, you need to examine these patients. You need to examine these patients. I have received 2 cases. I have received a case really of a patient who came to me with a foot problem in toeing of the foot. And I examined the patient. I told them to go on the floor to stand, and they had positive goers. Another one also came to me with a problem with the foot again, referred. The father says this guy has trouble even going up the stairs. I took him out to go up the stairs, and he struggled. And both of these cases were Duchenne's muscular dystrophy. Okay? Both of these cases had Duchenne's muscular dystrophy. And what is really sad is that the mothers had not been told. Okay, the mothers had not been told that it's Duchenne's muscular dystrophy. And in one of the cases, the mother was pregnant with a child. So guys, really, we have to examine patients. We have to examine patients. So that's Duchenne's muscular dystrophy, Gowers sign. Very sad. Okay. What about this? Does somebody know what that is? What test that is? Anyone? So this is the Thomas test. Yes, it is a Thomas test. So in this test, you're trying to establish whether the patient has a fixed flexion deformity. You can do the Thomas test in 2 ways. Number one, you can tell the patient to flex both the hips, and then you return the other hip to the couch, or you can do this one. This is definitely a way of doing it, where you tell the patient to lie down and they flex the hip, and then you see if the other hip will rise. Okay. So this is another one, very important test. Okay. Yeah, this is another one.
Shoulder apprehension test.
Shoulder apprehension test. So always know that if you have a patient who has a recurrent dislocation, and this is important, so when I was teaching you guys, somebody gave me a call about a patient, and this who I'm going to see later in the day and probably operate later. But this is a lady who is a 46-year-old, very strange history. She came in. She's just presented with a dislocation of the shoulder, which has been there for a week, which is very, very strange. Okay, so she thought that it was not a bad injury, so it's actually dislocated. So it's been there for a week. Obviously, the registrar has tried to reduce it and has not succeeded in reducing it. So the plan is for us to do it either closed reduction in theater, or it may need an open reduction in theater. Okay. Now, I want to say one thing. So these patients who have shoulder apprehension, okay, these patients who have shoulder apprehension, the reason you're doing this is to, if you have a dislocation, I think I've said it, below the age of 30, no, below the age of 20, there's a 95% chance it will recur. If you have a dislocation above the age of 40, there's a 10% chance it will recur. Okay, so these patients, so please, if you have a patient with recurrent dislocation, refer them to somebody who will fix them, because two things happen when you have recurrent dislocation. Number one, what happens is you have, when the shoulder dislocates, there's a reason why the shoulder will keep on dislocating. It has what is known as a Bankert lesion. A Bankert lesion is a defect on the anterior inferior aspect of the glenoid. But also when the shoulder dislocates, you can imagine the humerus head goes in front of the glenoid, and that creates a dent on the humeral head. So you have a defect on the humeral head. So recurrent dislocation is not very good, because usually we treat it arthroscopically. I prefer to treat it arthroscopically, something called arthroscopic stabilization, Bankert repair. Sometimes we treat it open with a procedure known as a Latarjet. But when you have recurrent dislocation, it's not very good. I remember seeing a patient, I think it was from Mandera, who had recurrent dislocation. And when I went to scope the shoulder was completely arthritic. So please, if a shoulder comes out, there is no point. If a shoulder comes out twice, it's going to come out again. Now, sometimes you bring for students this, and you ask students, what is the diagnosis here? And sometimes a student looks at you and you wonder what is wrong. How do I help this one now? What's the diagnosis in? That's not what I only do. I mean, for sure, if I'm setting a question, I'll have to set a food thing. So what is the diagnosis in the first image? Somebody tell us.
A bunion.
Yeah, it's a bunion or hallux valgus, okay? And what about on the second image? It's the opposite of hallux valgus. What is it?
Hallux varus.
This is hallux varus, okay? So please, I mean, there are only so many images I can ask from. So please, guys, just know. What's the diagnosis in the first image?
It's
a volar wrist ganglion, okay? And usually it is associated with, it is usually wrapped around the radial artery. So when it's wrapped around the radial artery, that's the reason why sometimes we may not necessarily, sometimes we may or may not excise it. But usually the one you'll be brought for is a dorsal wrist ganglion. And we have gone through the other one, which was a paronychia. This test is, like we said, this is another way of checking for. This is the Thomas test. Now, what's the diagnosis here? It's a very common condition.
a trigger finger.
It's a trigger finger, okay? Trigger finger. Now, a trigger finger is, I think it's called stenosing vaginitis, tenovaginitis. And it is usually the patients have a nodule, and this nodule goes below the pulley system in the hand. I don't want you to know too much. I just know that trigger finger, initially you can just inject the flexor tendon sheath with a steroid, and that usually solves the problem. Sometimes you need to do surgery in terms of releasing the pulley, the A1 pulley, and that will solve the problem. All right. So that's a trigger finger. Now, this is me doing a procedure. So what is the diagnosis there? Somebody tell us.
Please play it again.
Pardon? What test is it?
Is it a valgus stress test?
Yes. Well, you put a valgus stress a bit, But that's not quite what it is.
Is it a pivot test?
This is a pivot shift test, okay? This is a pivot shift test, and what I'm checking for is the ACL. Is the ACL injured or it is not? We're about to repair the ACL, okay? And this is the Fromet sign. So, and Valhalla's valgus. So, now, but you are being asked, what is the diagnosis, the second toes?
Hemato.
Hemato. So, guys, you can see this exam is very easy to pass. It's very, very easy to pass because Dr. Oburu can only ask so many questions. He cannot ask you ridiculous things. Yeah, I cannot invent questions. So please, if you go through all those questions in Ortho tutorials, you will find the answers. Yeah, there's no reason why you should pass. You know, in the exam, you have to be strategic. Like all the guys I've taught, I usually say I don't like teaching for the exam because all of you will pass anyway. In any case, even if you don't pass here, you're going to pass ophthalmology or ENT. I'm not despising those specialties. But guys, you have to be strategic. You know, if you're going to be asked, yes, it's true, you'll be asked essays and also MCQs. You know, the secret of MCQs is just doing as many MCQs as possible. With regards to essays are a bit tricky, but I think essays are falling out of favor. But just go through all the questions in Ortho tutorials. I will try and add a few if I can before your exam. But please do not spend time reading chapters and chapters and chapters of DDH or Skife or osteopetrosis. It will not be, you'll not be asked those questions. What's the diagnosis here? Does anybody know?
Winged scapula.
The winged scapula. So you can have a winged scapula can either be caused by either injury of the long thoracic nerve or injury of the spinal accessory nerve. You know, I think for you guys is just to appreciate that this is a winged scapula. Yeah. For the orthopedic surgeon is to know which one specifically has caused it because it will determine the operation we will do if we need to. That's a gunstock deformity. And you can see a theme because what I did is I just basically got various past questions that have been asked. And you can see there's just a theme that some of these questions repeat themselves. Okay?
What is the gait demonstrated
you see,
by the right lower
this is the gait again, is high steppage gait. Okay? Yeah, I cannot invent another gait. So, okay. What's the name of the test? It's not been properly shown here. What's the name of the test?
Tinels.
This is Tinels test. A Tinels test is basically tapping a nerve and seeing if you can get distal sensation or whatever after. You understand? Well, distal tingling. Okay? So these are Tinels tests. Though, where it's been illustrated is probably not the best because that's not exactly where the carpal tunnel is. The carpal tunnel is a bit more distal, okay, to that. And it obviously signifies a carpal tunnel syndrome if it is positive. Okay, what is, like you said, you need to go through all of the knee examination. What's the test here? What's the diagnosis? What's the diagnosis? You can see from the test. What's the name of the test?
Anterior draw test of the knee.
Actually, this is not anterior draw test of the knee.
It's the
Lachman's test. So for anterior drawers test of the knee needs to be flexed at about 90 degrees. But in this case, you can see that the knee is not flexed at 90 degrees. The knee is flexed at about 30 degrees. And, you know, you're pulling forward. This is that. What is the management in a 70-year-old? So you can say this is positive. So how would you manage a 70-year-old? Sometimes you ask the student that and they give you a ridiculous answer. Na bado wanapita tu. How do you manage this in a 70-year-old? Supposing the anterior door access was positive. What do you think? Anyone? So in a 70-year-old, if you have an ACL, unless this guy is a ridiculous fitness freak, unless he's a crazy fitness freak, you know, some people, especially some cultures, wazungu wanapenda easy, they do, and some of you are like that. They do mountain climbing, I don't know, abseiling, rock climbing, all sorts of skiing, all sorts of things, which I am not quite sure how they help. But anyway, usually it's non-operative, okay? Usually in a 70-year-old, it's non-operative. In a younger person, it's different, okay? And you can see over here, again, one showing winging of the scapula. Yeah. And we have gone through the nerves that could be injured. Now, this is another test that usually, I think you guys, I try to endeavor to teach people physical examination as much as possible when they come to my ward. And if you look at this test, in this test, you find that you are trying to dorsiflex the ankle with the knee extended and with the knee flexed, okay? And if there is a major change, you determine whether or not the gastrocnemius is contracted or the soleus. I don't know why I teach this test to undergraduate. Maybe it's just the excitement of being a foot surgeon. I'm not quite sure it's very useful, but for a surgeon, it's very, very important because you want to determine what you will address, whether it's the gastrocnemius or this. So this is shown here. So you can see when the patient dorsiflexes that the ankle dorsiflexes even more. So you can see the position of the ankle. That's the position of the ankle. But when they dorsiflex the knee, the ankle goes farther, okay? So that means that what is tight is the gastrocnemius and not the Achilles tendon. So when you're releasing stuff, that's what you concentrate on, okay? You release the gastrocnemius. All right. What's the diagnosis here? This is called a Sparling's test. Yeah. It's test or sign, I'm not 100% sure. And what does it mean when it's positive? The patient has cervical spondylosis. Okay. Then, like we say, gait. What gait is this? Anyone, any gate? What's the name of this gate? What's the name of the gate here? This is a short limb gate. You can see that. So obviously the left side is short. Okay? Sometimes you have to look carefully. And remember what we said. What gate is this? Anyone?
Scissoring.
It's a scissoring gate.
Diplegic gait.
Pardon?
Is it diplegic?
Yeah, it is usually in diplegic, okay? It's usually in diplegic patients, but it is a scissoring kind of gait, okay? It's usually in diplegic cerebral palsy, but it is a scissoring kind of gait, okay? Now, this one many people did not get, but you always get one crazy student or two who get it. So you can see the patient is really struggling to raise that heel. So what is this? This is called a single heel raise test. You can have a double heel raise test or a single heel raise test. And in the single heel raise test, what you're trying to do is you're trying to check if the tibialis posterior is functional. Okay. If the tibialis posterior it's functional, the patient should be able to do this without a problem. And sometimes you need to repeat this a number of times, okay, to see if the tibialis posterior is functional. Obviously, if you have a condition known as a tarsal collision, and also you want to check if the foot goes into a bit of varus, okay? You can see the foot is valgus there. So can the patient raise and is the foot going into a bit of varus? Because you need two things to happen. Number one, the tibialis posterior needs to be functional. Number two, your subtalar joint needs to be supple. Yeah? And I would add something else, but that is really beyond your scope, really. That's more for foot and ankle surgeons. Okay? So that is a single heel raise test. Now, okay, so now somebody was asking questions about, all of us can agree that number A is mallets. We can all agree? Yeah, mallet finger. Number B is?
Swan neck.
It's a swan neck deformity. Remember, hyperextension of the PIP and a flexion of that. And number C is?
Dupuytren's contracture.
It's Dupuytren's contracture, okay? Not commonly seen here, very commonly seen in the West, but you may find it here. This is an important test, okay? That's important. You need to have a high index of suspicion. But what is the diagnosis here? If this test is, what's the name of the test?
Hook test.
This is a hook test, okay? And you want to check whether the distal biceps tendon is ruptured. If it's ruptured, obviously, you need to fix it. Once again, guys, it's the same thing over and over again. Okay? Because there can only be certain questions that will be asked. All right. And see that? That's circumduction. Okay? Caused by a stroke. Then this one I brought last year. Okay? I don't know, somebody could try this here. What's the diagnosis here? And you see, whatever I bring, there has to be a reason I'm bringing it like that.
Could this be an osteochondroma?
These are osteochondroma because you can see I'm bringing I have brought the limb, I have brought the tumor on X-ray, and I've brought something with a cartilaginous cap. So that is an osteochondroma. What are the two possible complications? It can compress the structures nearby, but also it can compress the structures nearby, but also it can also turn malignant, which is very, very rare, but possible. What sign is demonstrated here? So guys know all the signs of, this is a Jobs test, okay, or empty cans test. And you're basically checking if there is power in the supraspinatus, okay? And checking if there's power in the supraspinatus. Then this was a makeshift question I brought last time. Some people never got it, but some people thought very hard. So, and look at always you look at the stem, because I want you to get the question, but I'm not going to tell you it's this, isn't it? So if we look at the stem here, I've said a 17-year-old from coastal Kenya presents with severe hip pain. Why have I said coastal Kenya? Why could I say Meru or Kirinyaga or Turkana? Yeah. So coastal Kenya, you have to ask yourself what conditions are specifically in coastal Kenya. And I have given you a very clear X-ray there. You can see the left hip, there's something definitely wrong with the left. The patient has severe pain. Yeah. So what are the options when it's advanced?
Could this be Perthes disease in a patient with sickle cell anemia?
Yeah, this is avascular necrosis in a patient with sickle cell disease, okay? avascular necrosis. All right? Because why did I say coastal Kenya? Now, if I would have said Nyanza, it would be even more obvious. Okay, but I didn't want to give that away. So I said coastal Kenya. Then somebody from Moyale, what can you see? What is the diagnosis? What's the foot? These are Madura foot. Yeah, sometimes people just stare at you blankly when you ask them, what is this? Now you also maybe stare at their marks blankly. That one we had gone through, remember? Campylodactyly and clinodactyly. Then this is, what is this? What's the mechanism of injury here?
Is it a boxer's fracture?
Not quite, not quite. Look at it has been marked over there.
Is this a bite injury?
This is a human bite, okay? So always be on the lookout for human bites, okay? And because usually they go up to the MCP, okay? The MCP is involved, and sometimes I think you need to take them to theater to be bridled. And treatment for these things, obviously medical students say, what is the organism? I don't know, is it Pichinella corridans or something like that? I'm not quite sure. And what is the diagnosis here? It's very straightforward. You know, nothing serious would be asked. What's the diagnosis? I just want you to know the diagnosis, not anything else. What can you see? There's definitely absence of a proximal femur, isn't it? Yeah? So these are proximal femoral focal deficiency, okay? So, yeah, proximal femoral. Then this one also, a patient presents 40-year-old with knee and elbow pain. You can clearly see what is the diagnosis in the elbow. What does the patient have in the elbow?
Olecranon bursitis.
Olecranon bursitis. And then the patient has knee pain. So if the patient has olecranon bursitis, then the patient has knee pain. I mean, there can only be one diagnosis. Yeah? Which condition is notorious for olecranon bursitis? And can also give knee pain. You guys know? It's gout. But it's not very obvious, but it's also pretty obvious. Okay? Then, what's the diagnosis? Here, you can clearly see what it is. It's a radial club hand, okay? And what syndrome must be associated, may be associated with this? Don't forget your Vactorel syndrome. And this one is an easy one, not very difficult. It's a little bit like the other one from the lady from Coast. So 3-year-old A&D with a fall. You do an X-ray and that's what you find.
Osteogenesis imperfecta.
This is osteogenesis. You can see the blue sclera. You can see the multiple fractures that have happened before. You can see these lines here. This is called Harris lines, okay? Harris lines. All right, so yeah, that is, that's it. And look here, like I said, only so much that Dr. Oburu can bring, another circumduction gate. Now, sometimes, you know, something you just have to look, okay? Tell me what the diagnosis is here. What's the diagnosis there? What is this patient unable to do?
Flex the DIP.
Flex the DIP. Okay, so if you cannot flex the DIP, it can only mean what? What have you injured?
Your FDP.
Your FDP, okay? You've injured your FDP, all right? So that is the diagnosis. What is the treatment of FDP injury? We said mallet finger, you put a mallet finger. FDP, what do?
Reconstruct?
Yeah, you have to reattach it, okay? You have to reattach it. Okay, now, what's the diagnosis here? Yeah, what's the diagnosis? It's a drop arm sign, drop arm. And the patient cannot control it, especially when they come from abduction and you tell them to lower it slowly. They can't. Why can't they? They can't because of one reason. Yeah. They can't because of they have an injury of the rotator cuff. So please know your Steadman-Hawkins drop arm sign. I don't think you need to go and just watch 2 or 3 shoulder examinations. And also try and ask yourself, what are they achieving? Like the job says, checking for supraspinators, external rotation, checking for teres minor and infraspinators, okay? Gabber's lift of chest, checking for subscapularis. So that when you're asked, you're in a position to say. Okay, so straightforward question. What's the differential diagnosis? Obviously here, maybe an ankle fracture, maybe a pilon fracture. And the first step we say about this is to reduce it, okay? So that they are okay. What's this? This could be a felon, okay? This could be a felon, which is a pulse space infection. And the treatment of this is incision and drainage. What's the diagnosis here? Sometimes you bring such a simple thing and people can't answer. It is so embarrassing.
Ingrown.
This is an ingrown toenail. Yeah, it can be a pain in the whatever. Now, an ingrown toenail is something that you guys can even do, as medical officers. If you're told, well, the secret is please make sure you get to the germinal matrix and you buzz it. Okay, I usually use diathermy. I used to use phenol when it was available. I don't have access to it. I usually use diathermy. Don't overuse diathermy for long. I remember I used to do that and I had wound problems. And then use it for about 10 seconds and you should be okay. So that's an ingrown toenail. And what's the diagnosis here?
Theta pes cavus.
These are pes cavus. Okay, so rapid fire, you can ask undergraduate what equipment this is, and some of them will not know. It goes to show you that they've been going to theater a lot, isn't it? What equipment is that? That's a C-arm of fluoroscopy, okay? Please, Yeah, that's positive apprehension. What test? What's the name of this test?
Galeazzi.
Is a Galeazzi to determine the limb length. And this one, this Trendelenburg, okay? You want to see whether the patient's Trendelenburg is positive or not. This was one of my colleagues, I don't say it like this. This is a bone forceps from a sign. What test is this? This is a Fallen test, okay? These are Fallen tests, okay? All right. And it may show that you do it for a minute. What test is this?
A squeeze test.
Squeeze test. And what is that squeeze test? If it's positive, what does it show?
The syndesmosis is injured.
The syndesmosis is injured. So this one we all know. What's this? What's the diagnosis?
Botanius deformity?
This is Botanius. And sometimes I ask, what is injured in Botanius? It's a central slip, okay? The central slip is what is injured. These are Allen tests. Yeah. What test is this?
Barlow's test.
Barlow's. So know the difference between Barlow's and Ortolani's test. And this is Thomas. Okay. So guys, that is a nutshell is the physical exam. That's a nutshell is also the data interpretation. So that is what will come in the exam. Like I said, just go through all those questions in order tutorials, it should be fine. Yeah. And I wish you guys all the best. I hope this session has been useful. Okay, we have finished it's 4 or 6 now. Any questions?
Dr. Oburu, I have a question.
Yes.
When asked to do a pelvic examination, is it the same as a hip examination, or are there some salient differences between the two?
A pelvic examination in orthopedics?
Yes.
Usually it's very rare you'll be asked to do a pelvic examination. You know, so even with examinations, you have to kind of like tailor it according to what the pathology is. Okay. So you have to tailor it according to what the pathology is. Okay. I mean, if you're being asked about a patient may have something like meralgia paresthetica, which is a bit of entrapment of the lateral femoral cutaneous nerve, then you will try and see if you can do what? You will specifically see test for that area that it gets into the thigh. Yeah. If a patient has got maybe sacroiliac pain, you may do a Faber test. So, but specifically, it's rare we ask just do a blank pelvic examination.
Okay, but in the event that perhaps you were asked, are there some salient features that you're supposed to mention?
No, and I'm not sure anyone will ask you to do a pelvic examination. Somebody may ask you to examine a specific nerve or examine the knee or the hip, but not a pelvic.
Okay, thank you.
Okay, Doc, someone has asked in the chat box for surgery OSCEs, when we are asked to do a lower limb exams, do we do the special tests as well?
It's really difficult. If I'm setting to do an exam, I will try and be very specific. Like I would say, do a neurological exam of the lower limb. Then I expect you to do motor, sensory, okay? Try and do the basics. Then you can do the special tests. Okay?
Okay.
Any other question? Well, if there are no other questions, it's now 4:09. Thank you so much for inviting me, Hassan, together with the other students. Thanks to everyone who took their time to attend. Yeah, we finished with 157, which is not a bad number. And I wish you guys all the best in your exam. And for your revision, I've told you already where you can get help. Thank you so much. And God bless and have a good evening.
And thank you so much, Doc, for sacrificing your time, and have a good evening too.
No problem.